PowerPoint presentation there.
This one here?
Mm-hmm.
If I could get you all in a group, thank you. Our next speaker is Patty Connor. She is the Director of the Office of Consumer Health Services under the Governor's Office of Economic Development.
Okay.
Her office is the acronym, and you're going to hear so many of these today, and I'll try to at least say it out the whole way once. So, Office of Consumer Health Services, OCHS, is responsible for the development and management of Avenue H, which you may have heard of. Avenue H is one of only 2 health insurance exchanges currently in operation in the country. Avenue H is currently operating the small business and individual commercial portions of the site to provide an online platform for Utah businesses and individuals who need health insurance coverage tailored specifically to their needs and budgets. Prior to joining the state of Utah, Ms. Connor spent 20 years in business and management positions in the health and welfare benefits field, working for Health Benefits America, ADP, and Ceridian. She was responsible for business development, client retention, managing client relationships, strategic partnerships, and overall service delivery. Ms. Connor led large cross-functional teams in multi-million-dollar accounts and projects serving companies ranging from 300 to 100,000 employees. Her experience includes partnerships amongst the carrier and broker community, as well as managing multiple vendor relationships. So I'd like to welcome Patty Connor.
Thanks, Heidi. Can everyone hear me okay? Hopefully I don't have to speak too loud. So Mark's presentation actually led directly into mine, which worked out perfectly since we really didn't get a chance to coordinate. Since I'm representing the governor's office, I'm going to talk a little bit about what the state is doing, and then more specifically about health insurance exchange, which is my area of expertise. So I'm going to go over the first items fairly quickly. So as we talked about from a Utah Health innovations perspective, we really wanted to look at affordability, quality, and accessibility. And affordability, as Mark mentioned, is really a key to this. It should be affordable not only to patients and consumers, but also to business and government who pay for those services. Quality, we need competition. Innovation should enable the healthcare system to provide affordable quality services, and accessibility. Affordable quality health services should become more accessible to more residents. That's exactly what Mark said on his in more detail. And I know you're going to learn a lot more about that in this afternoon session, as well as tomorrow, about what we're doing at the state level. So we have really 6 key reform initiatives from the state perspective. And we started back in 2005 trying to develop from a state and a community and a hospital and provider network, identifying what are the things that we could do at a state level to improve healthcare within our state. So the first one is information technology, which is how do we set up the ability to share information, gather data, and use that data to improve our healthcare. We also have to deal with our healthcare workforce. Do we have enough? Are we being able to meet the demand in the future? And do we have a coordinated workforce? Next is wellness. This one, we felt like there were winnable battles in the state, mainly in the area of obesity, tobacco use, prescription drug misuse, and cancer. So the focus is on how do we educate the community on all of those components, create a culture of wellness, and make people aware of their choices so that they make healthy choices, which will end up being the right choices in the long term. And then payment reform that Mark talked about, and a lot of what the Beacon Project has been involved in. And then the next is the medical malpractice and tort reform. We've been working on this one for quite a while and trying to figure out a different way to address this problem within our state. And I think we're getting close to some solutions, but really been focusing on how do we gather the data and then share that data and come up with a feasible, non-traditional medical liability reform. And then finally, the health insurance exchanges. So I'm going to spend a majority of my time talking about this part because I know that there are other discussions on the first element, so I'm not going to go over all of them. So the first thing from a health insurance perspective is we want it to achieve a program sustainability, plan for exchange that integrates the individual need for program and plan choices as opposed to just having one choice, and then plan for the post-2014 disruption of the non-group insurance market. So many of you heard back in last May, the feds offered each of the states an opportunity to run a state-based exchange. And the states were having problems with that because the direction from the feds had a lot of strings attached to it. So they gave us three options. They said you can run a state-based exchange, which the state will completely own and operate. You can determine a lot of the rules around it. It could be your technology, and we'll give you money through federal grant to help build that solution at your state level. The second was a partnership exchange. The feds operate the exchange, but the states can handle the customer service issues and what is referred to as plan management or oversight of our insurance market. And the third one was a federally facilitated exchange. And this is completely operated by the feds, including customer service and insurance market oversight. There are many states leaning towards that federally facilitated exchange because they weren't supportive of the Affordable Care Act. And as a result, they just said, fine, you do it if you think that you can actually make this thing work. We're not going to have anything to do with it. And again, I'll mention that the federal grant money was available in all of the situations, depending on if you wanted to handle one of those three options. So we evaluated long and hard. Mark, as you heard in his introduction, was part of our advisory board, and we spent a lot of time debating about what do we want to do at a state level. And we had some major concerns. First of all, many of you guys know that in 2009 we started a health exchange, which was pre-ACA. We actually launched it in August of 2009. The Affordable Care Act was passed on March 10th of 2010. So we already had laws on the books to allow us to do an exchange, and we felt like we should have been grandfathered to a certain extent, and we didn't like a lot of the things that came out in the Affordable Care Act that really tied our hands in being effective in what we were trying to accomplish. So we really looked at what were all of the concerns. First, public versus private insurance. Our exchange and our direction from a state perspective was to focus on the private insurance rather than create more public programs like Medicaid and CHIP and Medicare, where people become reliant upon the system, and it requires more government money to do that. So our focus was how can we create a partnership with private insurance and help people get access to the care and quality on that side of the equation. Second was the federal oversight. Even if we do a state-based exchange, we have to follow the rules of the feds. I hear this referred to as Mother May I all the time. Every time that we want to do something, we have to ask the federal government if it's okay. Our track record so far with the federal government has not been great. Every time that we find an innovative way to do something that could reduce our costs at a state level, we have to go ask the federal government, CMS, through Health and Human Services, can we do this program? And it goes through a long evaluation process, year and a half, 2 years, finally for the feds to tell us, no, we don't think that's the right thing to do. No good answer why, it's just no. So we get frustrated with that. Time and time again, we have taken waivers to them where we felt like from a state government, we could do a better job because we knew our market and we knew our demographics, that we would be able to control those costs a lot more effectively than they would. So far, with that track record, we said, boy, if we go down this path and we have to, even though it's a state-based exchange and they say we have control, we know we don't have control. We still have to follow the letter of the law. We have to be certified by them, and they're going to monitor everything that we do along the way. So the next thing was a desire to preserve our state's pre-ACA decision to operate our small business exchange. We felt like we had the right equation, and what they put in the laws wasn't necessarily the right equation. The tax subsidy calculation concerns. So this is the advanced premium tax credit that would be on the individual side of the market, where you can get a subsidy to help pay for your private insurance if you qualify between that 100 and 400% of federal poverty level. Under that category, that is all a tax subsidy on your federal taxes, not your state taxes. And the federal government wanted the states to actually calculate that on behalf of individuals. And everybody had a lot of heartburn over this because it's not our tax in which to calculate. and determine if somebody should get an advanced premium tax credit. And then a big concern about clawback. If it's calculated incorrectly and your income changes throughout the year, then at the time you file your 1040s in April of the following year and you overestimated how much money you should get as a subsidy, the federal government will take that money back from you through your taxes. And so that has not been widely educated in the community, but that's actually what's going to happen. And we as a state felt like it was something that we did not want to get involved in and have to have that accountability for. So the last item was the mandate and the employer penalty enforcement. We started our program in the state as a voluntary. And I'll tell you that mandates were on the table early on, but was not acceptable by a lot of the legislator and policy people. And so we decided to go away from mandates and stay to a voluntary program. Unlike Massachusetts, who started a couple of years before us, they mandated the individual market everybody have coverage in the individual market, and they have over 225,000 people in their health insurance exchange, but a majority of those people are on Medicaid. They increased their Medicaid rolls by forcing the mandate to have health insurance. And we felt like it still needs to be voluntary, give people access and make it affordable, and they will come instead of forcing them to do so. And Mark talked a lot about this on how that three-legged stool on how do we make this whole thing work. So we didn't like any of the options the Fed gave us. We came up with the fourth option, and we referred to this as a bifurcated approach. So we actually said, we've done this before, where we say 3 different doors, and we picked door number 4 instead of the 3 that they gave us. So we want to split the roles with the federal government. And in the bifurcated approach, it means to split, and in this case, we are clearly splitting responsibilities. So we have asked HHS to run the individual market. Utah is going to run the small business market, and then we retain control over our insurance market. And Utah has the final determination of our Medicare approvals, or Medicaid approvals. I'm sorry, it says Medicare up there. And then we were approved May 10th by HHS, if you heard the announcements in the governor's press conference a couple of weeks ago. Finally, through long negotiations, we actually presented it to them on February 5th. We received on January 3rd conditional approval as a state level in order to run a state-based exchange. But after we went through the application process, we took a step back and reevaluated which was the best approach to do. And in that process, we conferred with our legislators and other policy makers and came up with this bifurcated approach, which was more acceptable to everybody. And the areas, again, that we had concern had a lot to do with the mandate, the advanced premium tax credit, and the fact that it was a lot of federal regulations. All of those forced us to go to this bifurcated approach. Even though we want to have a good experience for consumers in this market, we were really concerned that the individual market is where most of that activity from the mandate standpoint was going to be, and we weren't ready to take that on.
In your example for Avenue Range, define small business.
I will in just a minute.
Okay.
Okay. Yes, you are ahead of me, Sherry. So here's what our exchange model is, and it does talk about some of this. So the first thing is we're going to, on the individual exchange, we're asking the federal government to administer the federal subsidies, enforce the individual mandate in the employer shared responsibility. This is where all employers over 50 employees has to have offer healthcare coverage to their 30 or more employees per week. And then they're going to run a full navigator program. A navigator program are really consumer assistance people in the community that will really do the outreach to the areas that don't usually get access to health insurance. So it's going to be the underserved populations, the culturally disadvantaged groups, so that we can educate them about healthcare and let them know what options are available. In our case, the feds are going to run that program for us, and they're offering grants to navigators right now in order to run that program. However, the grants that they offer to Utah is pretty insignificant, and I don't know how much of an outreach is going to have. They only offered $600,000 for the first year, and if we have a couple of organizations that apply to do this, that $600,000 is not going to go very far. So we're going to have to get very creative in how we do volunteer projects and do a lot of education throughout the community to let people know what's available. And then the other thing the federal government will do is design and operate the risk adjustment and reinsurance programs inside and outside of the exchange. This whole program on the back end side, on the insurance side, has to have a way to balance out the cost. So we're going to have everybody in the pool, so guarantee issue, no pre-existing condition. We're going to drop our high-risk pools. The federal government's already made a decision to stop their PSIP program, which is their pre-existing high-risk pool. That program and our state health insurance risk pool or high-risk insurance risk pool are all going to dump into the individual market. In addition, we have all of the people who have never had insurance before, and any of the large or the employer groups that decide not to offer insurance in 2014 will drop into the individual market. We don't know what that risk is going to look like, so they built in these mechanisms on the back end side to help us manage the risk on the back end side. And unfortunately, the back end side, we don't see any of the dollars come back into our state until July of 2015, which by that time our insurers will have already rated 3 years consecutively before they even see any risk dollars coming back in. And we wanted to run the risk insurance program on our side of reinsurance and adjustment, but the feds would not let us do it this first year because of the way we did the bifurcated approach. So we're fighting to get this back for next year so that we can do it, because we feel like we can get a better adjustment of our dollars here than if we did it at a federal program. And I can answer more questions if you have on that. So Utah and the individual exchange will retain oversight of the individual market in and out of the exchange and make recommendations for qualified health plan certifications. This is a responsibility of our Department of Insurance. So it's really saying that they have oversight of the insurance market, whether it's an individual or small business. They're going to choose the quality health care plans, and then they're also going to do the evaluations of the rates, and they'll turn them over to the feds and say, these are the individual insurers or products offered by our insurance companies in the state of Utah that you can offer on the federal exchange for Utah. And then retain authority to give final approval for Medicaid. So the feds are going to do an assessment after you complete the application, and then based off the assessment, if it looks as though they are eligible for Medicaid, they'll pass that record over to our Department of Workforce Services, who will do the final determination if it meets state requirements. If they're not eligible, they'll send them back to the federal exchange and let them get an advanced premium tax credit. If they are eligible, they'll enroll them in Medicaid and manage them here at the local level. And then we may seek approval for the use of a state risk adjustment model for 2015, as I mentioned earlier. So the employer exchange. So the feds had agreed not to operate a competing employer exchange. It's referred to as a SHOP, a small employer health options plan. So we said, since we already have one, we do not want you to run in competition with us. And they quickly backed off on that and said, okay, we're all right with that. And then to operate a risk adjustment inside and outside of the exchange. So they're going to do that piece until we can take it back in hopefully 2015. And then we're going to continue to operate Avenue H as our state-based small employer exchange. We do not submit information to the federal data hub for enforcement of the individual mandate or the employer's shared responsibility. So there's absolutely no connection in our small business exchange to the federal hub or any reporting that we're doing for 2014. We have yet to determine in 2015 if we have to. We're going to run a navigator program only for navigators, and we're only going to pick two organizations that can help us get to small businesses. We're really not interested in the individual market. We're interested in help with those who have alliances with small businesses like Chamber of Commerce's business, the Small Business Administration that can help us educate on employer benefits. And then retain oversight of small group market inside and outside of the exchange. Again, Department of Insurance will make the decision on which plans we're going to offer and if they meet the quality healthcare plans. And they may seek approval for use of the state risk adjustment model. So real quick, on our exchange model, employers continue to have choice. So we offer today over 140 different healthcare plans that go from rich benefits of $500 deductibles up to high deductibles around $5,000 per month, or I'm sorry, $5,000 per year. Those plans are going to change as a result of the quality healthcare plan requirements that we have. Under the federal solution, for those 30-some states that are going to opt to the feds, they only get one quality healthcare plan to choose from per employer. We're going to still have choice. We currently have 3 insurers on our exchange: Regents, Select Health, and UtahHealth. We're in the process right now of identifying others that might be participating with us in 2014. Arches, which is a new co-op, will for sure be in there for 2014. We're still evaluating some of the other plans to see if they are going to apply to be eligible. We think that when we're all said and done, there will probably be close to 80 plans that people will have to choose from in 2014. And again, then we'll have a variety of benefit levels. Employers continue to have a consolidated billing. So in our process, they get one bill. So as the employee chooses multiple carriers and multiple networks, the employer still gets one bill. And then we do an ACH sweep, and we take the money out of their account, and then we pay all the carriers on the back end side of things for them, so that it's an ease of administration. Under the federal solution, they could not pull it off, so they postponed it until 2015. So they will not have that ready. We'll continue to do education and outreach. Brokers continue to assist the employers and the employees, and the employer participation rate will still stay at 75%. So today under small group, and it's 2 to 50 employees defined small group. However, under the ACA, we have to have 1 to 50, and 1 is an employer with 1 employee. So only 1 person has to enroll. If you're a sole proprietor, you'll go to the individual market. And our state has a 75% participation requirement for small business. That means 75% of your eligible employees that are 30 hours or more must enroll in healthcare coverage. Then we subtract waivers, or what we consider valid waivers, anybody who has coverage at another source, so like a parent's plan, a spouse's employer plan, Medicare, Medicaid, TRICARE, CHIP, all of those are considered valid waivers, and that doesn't count against the group's participation requirement. We've been operating under that for the last 3 years. We'll continue to operate under that in 2014. And then the employer funding flexibility continues. So we have what's referred to as a defined contribution model. And in the defined contribution model, the employer can set a fixed dollar amount that they can afford from a budget standpoint to pay towards their employees' plans. So if the average is $430, they can contribute $430 per employee per month. The employee then comes in and shops on the exchange and picks which of the plans is best for them and their family. So every employee with a group of 10 employees, everyone can have a different plan and a different price tag. And then new things that we'll do in 2014 real quick is we'll update our website, our call center, and everything to handle the Affordable Care changes. We'll have it available in English and Spanish. We'll have at least 2 state licensed navigators, as I mentioned earlier. We're offering standalone dental and vision. We had planned to do vision, but it's prohibited by the ACA, so we backed off on that piece. But we are going to offer a standalone dental and health savings accounts as we currently have today, in addition to the medical plans. And then our new rates are not based on health factors or gender, and I'll talk about that in just a second. And then exchange participation qualifies certain employers to receive federal credits. So there's a small employer tax credit available to the employer for those who have 25 or less employees. if they'll contribute 50% of the cost of the premium towards the employee's coverage.
Patty,
Uh-huh.
I understand you correctly to say that the federal exchange for shop exchange in those states, individuals within an employer would not be able to choose their own plan, that each employer chooses a plan and that's it?
That's correct. So the feds, it is part of the ACA that you have choice available, but the feds are not able to pull it off. They blame it on the insurers, but those of us who are closer to the market know that's a quick blame. We just don't think that they've figured out how to do it technically, which is not that big of a challenge. As a matter of fact, choice is harder to do than it is to limit the choice. But if an employer, and I'll just use Texas as an example, is going to go on the federal shop side of it, they will have to pick one plan and their employees will be in that plan regardless. There's absolutely no choice. The only thing that's going to vary is their rates. All their benefits will be exactly the same carrier.
I know if a big company sort of evolving, but I mean, I just think of small businesses, I think it really struggle still to pay the premiums for people. And then if they, and so what I'm going to do is I'll make sure I don't have anybody work 30 hours more because then I have to pay more, it sounds like it might. So then the state picks up that?
No, actually it doesn't. So everything that we're doing from a state perspective here is all private insurance, and the state is not augmenting any of it at all. This is a way that we've developed to create a sustainable program. It's not one where the government's going to help with it. Through this process, though, we are creating competition, and we are creating an opportunity to be able to do side-by-side comparisons and choice so that they can choose something that's right for them. And then we gave the flexibility to the employer on the other side to determine how much can they really afford. Instead of in the traditional market, they have to contribute 50% of the premium. If they can't afford that, that's one of the reasons why a lot of small employers don't offer the coverage. We're a small business state. We have 67,000 small businesses in this state. 50% of our employees in the state work for a small employer, and we know that somewhere between only 50 to 60% of them are currently offering insurance today. So we're trying to come up with an equation to help the rest of them get insurance, whether they stay in small group or they go to the individual market and get the tax subsidy. Those that are under 50 will not be penalized if they don't offer group insurance. So their employees can opt that direction, but we think that our equation actually will help with it but the small group actually has a different risk pool than the individual market does. I mentioned earlier that we're dropping the high risk pool and everything into there, the uninsured. We split our risk pool beginning in 2014 to keep our small employer separate so that we can keep their rates lower and be able to offer a better product, we believe, in the small business side. I have just a couple more slides and then I'll open it up for some more questions. So just a history of Avenue H. Again, we launched in August of 2009. We started in January of 2010 with a limited number. We started a beta program. Nobody was doing this back in 2009, or even since then. We are the only one that has launched a small business exchange, and to this day are still operating at. Granted, our numbers aren't as good as we'd like them to be, but we started out with 11 employer groups, 380 covered lives. In January of 2011, we reopened it again for all small employer groups to join, and we've been taking enrollments since January of 2011 every month. Last fall, we rebranded as Avenue H, a health insurance marketplace. We rebranded because we called ourselves Utah Health Insurance Exchange, and then the Affordable Care Act came out, made an exchange a bad name, and we couldn't get out from underneath that activity happening at a federal level and all the conversations that are exchanged. It was part of the ACA, therefore it was bad. So we rebranded and called ourselves a health insurance marketplace, and 3 months after we did that, the feds changed the word exchange to marketplace. So again, Utah's being an innovator here in coming up with all of the new names. On our statistics today, we have 344 employer groups. We're covering a little over 8,000 lives. And the thing that we keep track of here from a state perspective is what % of those were previously uninsured. So 69% of the group, or the individuals that are on Avenue H today, were previously uninsured. So it does tell us that we are reaching the market that we need to reach. We're not necessarily going after those that already have insurance. They're welcome to come join, but we want to make sure that people, the groups that couldn't get insurance before, take a look at the options that are available and the reasons why this program was set up in the first place. So last thing is some of the changes that are coming for 2014. First is the Essential Benefits Package. We benchmarked in Utah after the PEHP Basic Plus plan, which is the state employees plan. And that benchmark has to have, I believe it's 10 areas of coverage. And I know somebody else is covering this somewhere along in their other presentations this week, so I'm not going to go over it in detail. But the insurers can use that base point then to build on and create their products. And when they do that, they have to create them in an actuarial value. So a 60%, 70%, 80%, and 90% value of the benefits offered. It does include pediatric dental. So that means, and it's required under the Affordable Care Act that it have it. Not a lot of our insurance plans are going to have the pediatrics, so we're going to do a standalone dental plan that includes coverage for adults as well as the pediatric dental in our program this year. The biggest part is the modified community rating. This is where we take that rule of no pre-existing condition and guarantee issue and find a way to rate differently. As a result, we can no longer require small employers to go through a health application as they do today. Everyone in the individual market and small employer has to complete a 5-year history of themselves and their family for medical and pharmacy use in order to get underwritten from the group. That changes in 2014, which actually makes it a whole lot easier for us to do our job, but it's not necessarily the best thing for the insurance market or for the economy. But what it will mean is for the individuals is the only things that we can rate on are age, their demographic location, and we will have 6 of them in the state of Utah, and if they use tobacco or not. That's it. So 2 people, different employers, exactly the same age and family composition will get exactly the same price for the products if they choose exactly the same thing. Before, if you worked for a different company, your rates could be different because of the risk that you associate it with within that group. And so that changes the dynamics of our market quite a bit. And then the rates are going to be developed using a rate build-up process for adults and children. So an employee and their spouse will be considered the adults. And then the children, there's an individual rate for each children. We only count the first 3 children. But if you have a college student who's over age 21, they'll be counted as an adult at the age of 21. And so the rates are going to have a very different feel than employee and family rates that we currently have today. And then, as I mentioned, we'll have to categorize the plans as bronze, silver, gold, or platinum, which follow those actuarial values. So people, when you come on to either the federal or the Avenue H marketplace, you will see the metallic levels of gold, silver, bronze, and platinum that will see the actuarial value. So a silver plan is one that's usually the 70-30 split, so you can get an idea of how that will rate in 2014. There's many, many more provisions of the ACA that I don't have time to cover today, and many of them yet to come. We're kind of struggling with the fact that the feds won't nail down the regulations at this point. It's taken them forever to get them to us for us to make decisions and plan. And today we're still getting them. We got a whole slew of them back in February, and we're supposed to be up and running by October. Every state is, to start accepting enrollments for January. And it's hard to program, I'm sure every one of you guys could appreciate this, to plan and program and manage if your target's always moving. And in this case, our target is constantly moving, and it actually feels like you're in a tornado most of the time because of the way the information comes to us. You have to try and sort it out, and it takes several months of conversations with people to try and figure out what's the intent and if we're going to be in compliance with the law. So I'll conclude there and take whatever questions that you guys have. None. Okay, great.
participate in this and send all of their employees to the individual?
They're actually, employers will have several options. So if you're a large employer, you still have either your grandfather plan, you can do a self-insured or fully insured. Large employers are not affected by this at all, except for if you don't offer insurance to your employees, you're penalized either $2,000 or $3,000, depending on the situation, for every employee that opts to the individual market, if they get an advanced premium tax credit. If you are under 50 employees, the employers are not penalized by not offering the group insurance, so all of their employees can go there. So I'll use a good example. I was talking with a group down in Moab. The majority of their employees are seasonal employees and don't meet the full-time equivalent, but they have 3 or 4 of them that would be full-time. They'll be able to get group insurance for the 3 or 4 that are full-time employees, and the rest of their seasonal employees will go to the individual market, or they can get assistance with the advanced premium tax credit. And even some of those might even be eligible for Medicaid under those guidelines. That employer is not going to be penalized in that process.
Do small employers under 50 who do offer health insurance to their employees, do they receive any kind of tax benefit?
They do. So the employer is eligible for that small employer tax credit. They can get up to 50% of their employer contribution back as a tax credit if they have less than 25 employees, and they contribute at least 50%. And our tools will let them decide what the 50% level is for their employees. And in an employee choice model, you don't know up front what your plan is, and you don't know what the costs are going to be. So you want to be able to have something that says, if I mock enroll my group of employees, what's the average premium going to be for each of them, so that I can come up with a formula of how much to contribute towards that. And the small employer tax credit is only available on Avenue H in 2014. This program has been available for the last 2 years in the traditional market as well as the exchange, but in 2014 it's only available on the exchange. Okay, other questions?
It seems like it's a good idea to try to get a lot more people insured. There are still going to be a lot of people who just can't afford insurance or decide that I want to spend the money somewhere else. So then they have medical problems, and does the state pay again for those people like they do today?
So today, if you don't have insurance and you go to the emergency room, the community covers that cost, right? The carriers take it on. It's not necessarily the states. We all pay as individuals. The state government doesn't bail them out, but we all pay. So for those people who say they can't afford it, a lot of them are going to end up in the Medicaid side of things. We, by the way, have not decided at a state level if we're going to expand Medicaid or not, which the Supreme Court gave us the decision, or said that HHS had to allow each state to make a decision if they want to expand Medicaid up to the 133% of federal poverty level. We have not made that decision and may not make that decision before the close of this year. We're still doing a lot of evaluation, and we're trying to come up with another solution that might be a state federal subsidy instead of putting more people on Medicaid and putting them on private insurance. But for those who don't get the coverage, pay the penalty, which for the first year it's like $93 an individual if they don't have coverage, which is nothing. That's cheaper than 1 month of insurance coverage. So a lot of them, especially the young invincibles, are going to say, I'd much rather go buy a new iPhone than I want to have health insurance, because I don't understand the value of it yet. And they go to get coverage. We're still going to end up paying for that care. I can guarantee you every hospital, every provider is going to find a way to get them on coverage as soon as possible and make sure that their claims are being paid instead of having to do it under charity care.
I'm just kind of curious. I hear people make that statement a lot about people that are uninsured communities. Yet what I see is a lot of hospitals have a charitable fund that they actually use. If it's a for-profit hospital, I'll use that to get a tax break. If it's a not-for-profit, you just assume that's their responsibility. Just kind of wondering how they square that. How do they see that cost gets passed back to the community?
Well, I'm not the best person to answer that. Hopefully somebody else in one of the other days can. Mark, you want to
So the way it works in today's market, the hospital has a charitable calculation they do more often than they have a actual fund that they sit on. They have their reserves, they have a calculation of how much charity care they offered. And what that effectively becomes is, depending on the hospital, some are more aggressive about this calculation than others. But what it effectively becomes is, for people who came into my hospital that had no payer source, how much of the actual charges did they end up paying, and the rest we write off to our charitable fund. Effectively, what they then do to turn that around on it, healthcare, there's a lot of money in healthcare, but it runs on fairly slim margins. So what they end up doing is, in their next negotiation with Regents or Select Health or whoever they're negotiating with, then they increase the rate for that, or they try to negotiate in the legislative process for a higher Medicaid rate. Medicare, they have, their national association try to raise it. So what they're doing is they're capturing that money that was not collected for people who are uninsured. Up front, they're paying it. It goes as a loss on their books, written off as charity care, and then they try to capture it in future rates. And so there's a transfer of that cost to those of us who are insured ultimately. It's not immediate, but ultimately
Yes.
we all pay for it.
Yeah, so we're all paying for
So
it.
they're paying for it.
So even, right, we're all paying for it either way.
But they may not be paying.
That's
No,
right.
very often they don't pay for it.
Right.
That's the reality.
Mhm.
And that's the flaw of our system, the way it's
Yeah.
Is that gonna lose, but I can't see how it's gonna resolve.
ACA attempted to fix that, but the penalties are too slim to really fix it.
Right.
They don't make it tough enough for an individual to say it. So people will still opt at $93. I mean, you do the math. There's a lot of people who say, I'll pay the penalty. That's easier.
Can you talk a little bit to that about the fact that under the ACA, for people who are required by insurance, it kind of reestablishes a true risk pool. And the fact that people who would normally go uninsured now are insured and are paying into that risk pool. Further, when you talked about wellness, the fact that employee or individuals would seek out more preventative, lower cost care because they can go to the doctor when they're initially sick and the cost is $120 versus waiting to go to an emergency room when it's very quickly thousands of dollars that you and I then all share.
I don't know if I need to add anything more to what you already said. That's all right. I think, as Sherry was saying, that's really the whole concept here. Is the whole program is based off of, let's get people into care by providing no-cost preventive care. So under their insurance plan, they can go to the doctor for all the preventive care so that we can prevent the long-term chronic diseases and help minimize all of that and kind of stop the vicious cycle. A lot of focus is put on wellness programs and incentives to do that as well. I know you guys are gonna hear a lot more about that as you get into more of the detail with the Beacon projects and everything else throughout the next couple of days. Okay, Stephanie says I am done.
Thank you so much.